Today's deep dive is based on Dr. G.S. Raju's YouTube. And honestly, the stuff we're pulling from this it's just absolutely mind-bending. We're looking at a concept that sounds like something out of science fiction, but it's a real life-saving part of medicine. We are talking about altered surgical anatomy.
It's a very clinical term, isn't
Okay.
it? But it hides just a really dramatic reality. We're not just talking about fixing a part or stitching something up. This is a complete architectural remodel of someone's insides.
Right. I think most of us, when we think about surgery, especially cancer surgery, it's all about subtraction.
Yeah.
You find the bad thing, you cut it out, stitch it up, done. But this is all about the reconstruction. We're looking at a procedure called an esophagectomy. And it's not what you take out, it's how you rewire the entire plumbing system so the person can actually function afterwards.
That really is the crux of it. When you do an esophagectomy, you're removing the esophagus. That's the vital pipe between your mouth and your stomach. The real challenge isn't just getting it out, it's building the bridge to span that new gap. I mean, how does a patient ever eat or drink again?
It's a huge logistical puzzle,
Yeah.
and it's all happening inside someone's chest. So to really get this, I want to start with the before picture, the baseline. We kind of know our own layout, but Dr. Raju's work really highlights the strict borders inside us. So remind us of the starting geography here.
Okay, so in a normal, unaltered body, you've got two very distinct territories. And they're separated by a big border wall, which is the diaphragm, a thick sheet of muscle. Above it, in the chest, the thoracic cavity, that's where you find the heart, the lungs, and the esophagus running down behind everything.
And that area has different pressure, right? The chest is like a vacuum to help you breathe.
Exactly. It has negative pressure. But then, below the diaphragm, in the abdomen, you have positive pressure. And that's where the stomach, the liver, the intestines, all that stuff lives. They're two completely different worlds.
And the esophagus is the tunnel that connects them.
It pierces right through the diaphragm at an opening called a hiatus and connects to the stomach. Now, the reason for all this surgery, the driver for our discussion, is esophageal cancer. When a tumor grows on a section of that pipe, you can't just scrape it off. You have to resect.
Which is the medical way of saying cut out the whole bad section.
Yes,
Gosh.
but just think about the physics of that for a second. If you cut out, say, 5 or 10 inches of that tube, you now have a mouth way up top, a stomach way down below, and a whole lot of nothing in between, a massive gap.
And you can't just stretch the ends to meet. It's not a rubber band.
You absolutely cannot. The tension would just rip the stitches. So that's the central puzzle. You need a new pipe, but you can't really use plastic. And transplants for this are incredibly rare and complex. So surgeons have to get creative with what's already on site.
This is the part that just blew my mind. They use the stomach itself, but not the stomach as we know it, right? They don't just yank the whole bag up into the chest.
No, not at all. There would be no room. Imagine a full stomach sitting next to your heart. It would crush your lungs. So they do what is basically origami with human tissue. They take the stomach, which is this J-shaped bag, and they use staples and scalpels to cut along its curve. They transform it from a wide reservoir into a long, narrow tube.
A gastric tube, that's what they call it.
Exactly. They literally fashion a replacement esophagus out of the patient's own stomach.
That is just incredible engineering. You're taking an organ made for churning acid, a storage tank, and repurposing it as a transit tunnel. But what about the blood supply? If you cut up an organ and move it around, doesn't it just die?
That is the #1 fear for the surgeon. See, the stomach is normally fed by several arteries. During this origami, they sacrifice most of them. They have to rely on one single vessel, usually the right gastroepiploic artery, to keep that entire new tube alive.
So the whole thing is hanging by a thread, literally.
A single vascular thread, yes. It's incredibly delicate. But assuming the tube is viable, you still have the main problem. The tube is in the abdomen. The gap is way up in the chest.
And this is the pull-up. It sounds as visceral as it is. They actually detach the stomach from its moorings and pull this new gastric tube up through that little hole, the hiatus.
They thread it right up. They bring an abdominal organ up into the posterior mediastinum. That's the space in the back of your chest cavity.
I just want to pause on that image. It's so radical. You now have stomach tissue sitting directly behind your heart and lungs. That just feels wrong.
Well, it is anatomically wrong, if you mean it's not the factory setting, but it's surgically essential. By pulling it up, they can finally reach the cut end of the original esophagus, way up near the neck or high in the chest, and they sew the two together. Circuit closed.
And that connection point, we should get the terminology right here, is the anastomosis.
Right. An anastomosis is just a surgical connection between any two hollow structures. In this case, it's an esophagogastric anastomosis. Esophagus meets stomach.
And because they've pulled the stomach all the way up, this is happening way higher than it's supposed to. Dr. Raju calls it a high anastomosis.
High in the chest, yeah. Sometimes even up in the neck.
Mmm.
So congratulations. The surgery is a success. The plumbing works. A patient can swallow a piece of fruit. It'll slide down what's left of the esophagus, pass through that high connection into the gastric tube, and on its way.
Mission accomplished.
Technically, yes. But this is where our deep dive really begins. Because we can't just say, okay, plumbing fixed, back to normal. It is not normal. It's altered anatomy. And just because fluid can flow through it doesn't mean it flows safely.
Right. We haven't just moved parts around, we've broken some of the body's fundamental safety rules. What's the big safeguard we lose in this process?
The biggest one is the valve. In a normal body, why doesn't your lunch come back up into your throat when you bend over to tie your shoes?
The lower esophageal sphincter, the LES.
The LES. It's a high-pressure ring of muscle right where the esophagus meets the stomach. It opens to let food down, and then it slams shut to keep acid and food down. A one-way door.
And in this new anatomy, where is that valve?
It's gone. It was part of the tissue they cut out. And even if some muscle remains, the whole area is so distorted, it can't function as a valve anymore. The gastric tube is, for all intents and purposes, an open pipe.
So there is literally nothing mechanical stopping the contents of that new stomach tube, acid, food, whatever, from flowing straight back up to the throat.
Nothing but gravity. And remember what we said about the pressure difference?
Oh, right. The chest has negative pressure. The abdomen has positive.
Exactly. So not only is the valve gone, the very physics of the chest cavity creates a slight suction. It actually encourages things to move up. The gastric tube is like an open chimney.
That sounds like a recipe for disaster. And that brings us to the biggest consequence in the source material, aspiration.
Aspiration, yeah. It's one of those clinical words that sounds kind of mild. But the reality of it is terrifying. It means you're inhaling liquid or solids into your lungs.
We've all had something go down the wrong pipe and had a coughing fit. Is that it?
It's much, much more severe. If you aspirate stomach acid, you're not just choking. It causes a chemical burn in your lungs, chemical pneumonitis. It can lead to terrible pneumonia, infection, respiratory failure.
And for these patients with this high anastomosis, the risk isn't just for a little while after surgery. It's a lifelong thing.
It never goes away. The valve isn't growing back, so if that material refluxes up to the back of the throat, and the patient takes a breath at just the wrong moment.
It goes right down the trachea into the airway.
Straight in. And this brings us to the real-world application. Dr. Raju isn't just explaining this for academic reasons. It fundamentally changes how every other doctor has to approach this patient forever.
Yeah.
Specifically when it comes to routine checkups.
Right. So a patient has the surgery. They survive the cancer. Fantastic. 2 years later, they need an endoscopy. Just to check up, right? Put a camera down, look around, make sure everything's okay.
In a person with normal anatomy, how do we do that? You go to a clinic, you get some moderate sedation, twilight sleep, you nap, I put the scope down, you wake up, you go home.
Pretty low stress.
But if you do that standard procedure on one of these gastric pull-up patients, you are playing Russian roulette with their lungs.
Okay, walk me through that. What's the danger?
You sedate the patient. Sedation relaxes all their muscles. Critically, it suppresses their protective reflexes. They lose their gag reflex. They lose that automatic cough that protects the airway.
And for this kind of procedure, you'd normally have them lying flat on a table.
Lying flat. So now you have a patient flat on their back with a gastric tube full of fluid. They have no valve to keep that fluid down.
Yeah.
And they have no reflexes to cough it out if it comes up.
The fluid just passively pours out of the top of that tube.
Into the back of the throat. And because the airway is wide open and unprotected, it just spills right into the lungs. It's called silent aspiration. They won't even choke or cough because they're sedated. You might not know it happened until they're in the hospital 3 days later with a raging pneumonia.
That is a chilling thought. You go in for a safety check, and you could cause a life-threatening injury just by not knowing about the plumbing change.
Precisely.
So what's the protocol? The source is very clear on the gold standard for this. How do you protect them?
If you are putting a scope down one of these patients, the recommendation is unambiguous. General anesthesia with endotracheal intubation.
So don't just sedate them, put them all the way under, and put a breathing tube in.
The breathing tube is the key. It's not just to help them breathe. The tube goes into the windpipe, the trachea, and it has a small inflatable balloon cuff near the end.
Oh yeah, I've seen diagrams of that. It's like a little donut around the tube.
That's it. And when you inflate that balloon, it creates a perfect airtight seal against the walls of the windpipe. The lungs become a sealed vault. Even if the stomach contents come flooding up into the throat, that fluid physically cannot get past the balloon.
You're building them a temporary dam, a replacement for the valve that's missing.
That's a perfect way to put it. You completely isolate and protect the airway. It turns a high-risk situation into a totally controlled, safe environment.
Okay, that makes complete sense. You mechanically guarantee safety. But there's always a but, isn't there? What if you can't do that?
Right. The real-world problem.
And the source does address this. Maybe you're not in a full hospital, no anesthesiologist available. Or maybe the patient is too frail and general anesthesia itself is too risky for them.
There are a dozen reasons why the gold standard might not be on the table.
So what do? Just not do the procedure?
Sometimes you can't avoid it. You have to look. And this is where medicine meets just basic high school physics. If you cannot physically block the airway with a tube, you have to use the only other force you have on your side, gravity.
The angle of the bed?
The angle of the bed.
Yeah.
Dr. Raju is adamant about this. If you cannot intubate, you do not, under any circumstance, lay this patient flat. You keep them elevated.
And they give a specific number, almost 45 to 60 degrees up.
Which is steep. That's not just propping their head on a pillow. That's basically having them sit up in a recliner.
I'm trying to picture a doctor doing an endoscopy like that. It sounds really awkward.
It is incredibly awkward for the doctor.
Yeah.
Normally we stand, the patient is at a comfortable height, lying down. If the patient is sitting up at 60 degrees, the doctor's practically reaching up to get the scope in. It messes up all your ergonomics.
But you're prioritizing the patient's safety over your own comfort.
100%.
Yeah.
By keeping their chest higher than their abdomen and their throat higher than their chest, you make it so much harder for that fluid to travel uphill.
You're using gravity to fight the reflex.
Exactly. You're making the liquid fight hydrostatic pressure. It mitigates the risk. It doesn't eliminate it, let's be clear. Intubation is still far, far better.
Yeah.
But as the source says, the risk for aspiration will be less.
And sometimes less risk is the best you can do.
It just highlights how critical a patient's medical history is. The doctor walking in has to know what happened inside that chest 5 years ago. If they just see stomach on a chart and assume it works like a normal stomach, they could make a fatal error just by lowering the head of the bed.
That's a great point. The names of the parts are the same, esophagus, stomach, but they are functionally completely different animals now.
And that's true for the patient's daily life, too. Many of these patients have to sleep on special wedge pillows for the rest of their lives. They can't eat a big dinner and then lie down for a nap. They have to live with gravity in mind, constantly.
So, to synthesize this whole journey, we start with esophageal cancer. We intervene with this massive biological engineering project.
We remove the diseased part, we sacrifice the valve, and we pull up a newly fashioned gastric tube into the chest to bridge that gap.
Creating that high anastomosis. But in doing so, we create a patient who is permanently, vulnerable to aspiration. We've turned their digestive system into an open chimney.
A patient who requires specialized handling from then on.
And for any medical provider, the takeaway is pretty binary, isn't it? Either you seal the airway with an endotracheal tube or you fight gravity with a 45-degree angle. There is no safe middle ground.
That's it. You have to respect the altered anatomy. You cannot treat the map like it's still the territory.
It leaves me thinking about how resilient the body is. We can completely reroute its most fundamental systems.
Yeah.
And it just adapts. It figures it out. But it only works if we, the people taking care of it, understand the new instruction manual.
That's the deep dive right there. It's not just about the incredible surgery. It's about the stewardship of that result for a lifetime.
So well said. This has been a fascinating look at the mechanics of survival. And as we wrap up, I want to make sure we give full credit where it's due for these insights. Today's deep dive is based on Dr. G.S. Raju's YouTube.
An incredible resource. You can actually see these things he's talking about.
Absolutely. Thanks for listening, everyone. Stay curious, check your angles, and we'll see you on the next deep dive.